everyone. Welcome once again. This webinar is proudly sponsored by Cardiocare Multispecialty Hospital, the home of excellence in cardiovascular medicine. Right, so today we want to talk about the diagnosis, management, and aftercare of the cardiac surgical patient, what we have termed the contemporary cardiac surgical journey. So after today's talk, I expect us to understand how to the 5 major steps in the continuum of the cardiac surgical care, which is one, the diagnosis, heart team consensus, which is the decision-making part, preoperative optimization, the main surgical procedure itself, and then recovery. Okay, now we'll ask ourselves this question: which patients need cardiac surgery? There is this misconception that cardiac surgery is the last resort, but then again, modern cardiac surgeries has gone beyond that. We should not ask ourselves, is surgery possible? But rather, when should surgery be done, and will it benefit the patient? We'll discuss this under 4 broad headings: the coronary artery disease, the valvular heart disease, the aortic disease, and then the congenital and other areas. Now, for the coronary artery disease, we know that not every patient with a stenosis vessel will require surgery, but rather, when we see patients who have a significant stenosis of the artery, we can consider them for surgery. The first being the left main stenosis, when we have a stenosis artery greater than 50%. Like the left main artery supplies the bulk of the myocardium. So when it is stenosed, there's no blood flow around the artery, and consider them for surgery. And the surgery here majorly is a coronary artery bypass graft. Then we have the multi-vessel disease with syntax scoring greater than 22, because those with syntax scoring less than 22, they are better off with percutaneous coronary intervention, that's the stenting. The ones that are above that 22, we consider them for coronary artery bypass graft. Those who have failed or complex PCI anatomy, who have chronic obstruction, who have severe calcification, and they've done PCI but it has failed, we still have recurrent instant stenosis, we can consider them also for surgery. They'll have STEMI with cardiogenic shock. Those who are they have mechanical complications like rupture of the ventricular septal wall, rupture of the papillary muscle, and free wall rupture. They're also suitable for coronary artery bypass graft. Is under the stenosis artery. We'll move away from there. Another major area is the valvular heart disease. Here, once they become severely symptomatic, they are qualified for intervention. We have the severe aortic stenosis. Here, there are actually 2 groups, those for TAVI and those for SAVI. TAVI is the transcatheter aortic valve implantation, which is preferable for those who are actually elderly, free, who have a high operative risk. And then the surgical aortic valve replacement, which is actually preferable for those who are young, those who have very low surgical risk, and those who are also other procedures alongside the aortic repair. We'll have the mitral regurgitation, where we'll actually prefer a repair than a replacement to preserve the left ventricular geometry and also its function. We'll have rheumatic valve disease. Here we can either do a repair or a replacement. We have endocarditis with structural damage. Here we'll consider them more when the valve is severely damaged And then there's also recurrent emboli, recurrent vegetation, large vegetation formation that we consider for surgery. Yes, there's a role for infection management, but for that damaged valves, you have to um, take it surgically. Then we have the aortic disease, where we have the thoracic aneurysm. That's when the ascending aorta is greater than 5.5 centimeters. Here, the aim of the surgery is to prevent a rupture or a dissection, which is now an emergency. We have the acute type A aortic dissection, which is actually the emergency where they present with sudden tearing chest pain. They have pulse deficits, aortic regurgitation, and then shock. These one level once we are taking them in for surgery. And then we have the chronic type B with complications and then connective tissue syndrome. Move to the congenital, where we have adults with congenital heart disease, like tetralogy of Fallot, the atrioventricular septal defect, and the single ventricle, where they have to actually be assessed and know if they're actually fit for surgery. We have cardiac tumors, the major one being the myxoma. Here we go in surgically in order to because at risk of obstruction, risk of arrhythmias, risk of embolization, so surgically preferred for them. We have also selected arrhythmia surgery. In case you have a patient with AFib, we can do a MIS procedure for them alongside other procedures. Perhaps they have also valvular disease, can do a mitral valve surgery for them alongside the MACE procedure. And then we have those patients who, despite being on guideline medical therapy, they are not yet optimized, they're on ICDs, they're on CRTs, and then we are not getting good, control. We can actually work them off for left ventricular assist device and also um, for cardiac transplantation. So then we ask ourselves the next question: how can a cardiac patient be evaluated? We have four major headings. We will have the clinical assessment, the non-invasive imaging, the invasive evaluation, and the risk stratification. We should not forget that even though it's surgical, history and physical examination play a major role in a cardiac surgery patient. And this, the clinical assessment entails the symptoms. Ask the patient, you want to know how symptomatic this patient is. Want to ask for chest pain, ask for dyspnea, want to ask for syncope, want to also know their classification based on the New York Heart Association classification. Are they symptomatic? Are they dyspneic on ordinary day activities? Are they dyspneic at rest? Are they dyspneic with mild exertion? This helps us actually classify them. Want to know also their risk factor because we classify them systematically, know how their outcome during surgery and also after the procedure, their prognosis. The risk factor profile, we want to know, are they hypertensive, are they diabetic, do they have chronic kidney disease, do they have do they smoke, are they obese? This helps us to also stratify them. We have to know those that functional limitation, can they go about their daily activities, are they wheelchair bound, um, um, can they take a flight of stairs? How much can they walk before they start having symptoms? This also helps. Also, the frailty scoring. This does not do the age alone. Also, not just the chronologic age, the biological age of the patient as well. Like what they can do. Do they have slow gait, any weakness, any exhaustion, dependence? It helps us as well. Despite after the clinical assessment, we move to imaging, what we want to know the structure, the function, the hemodynamics of the patient, and also the tissue characteristics of this patient. For the non-invasive, the ECG and the Holter helps us. It helps to know is there any ischemic changes, any prior infarction, any left ventricular hypertrophy, are there any arrhythmias, any conduction abnormalities, helps in evaluating this patient. And then next is the echocardiography. This is one of the most important tools in the cardiac surgery. We have the transthoracic echocardiography, we have the transesophageal echocardiography. The transthoracic actually helps us to know the ejection fraction, the chamber size, any valvular abnormalities. Then the transthoracic helps us even intra-op. It guides us. It gives us a clearer image of the valves and what we're doing intra-op. We have the CT angiography, which actually helps to show the coronary anatomy and also aortic diseases. Now it's making way because now it helps us in aortic disease to know the size, the extent, the location. So it plays a role in the assessment of the patient. And the cardiac MRI gives us a better view. It answers the questions that the echo cannot answer. Helps us in tissue visualization. It helps us to know if this scar tissue is actually a scar tissue or this microbiome is viable. Helps us in infiltrative disease and so on. Sometimes one can get a good view, a good um, answer will be non-invasive. We move over to the invasive evaluation when the coronary angiography is done, which is the gold standard to show the coronary arteries, the anatomy. It helps us train our pen guess for a patient for cabbage. We have the right heart catheter, shows us the pressure in the right atrium, the right ventricle, the pulmonary arteries, even the cardiac output. Helps us in working with the patient for transplant surgery, also for left ventricular assist device. We have the pressure wire, that's the fractional flow reserve. Well, when we see a stenosis artery anatomically, not all of them are functionally significant. So sometimes when the artery is stenosed and we perform this investigation, we see that we can actually do that, then they are functionally insignificant. So it helps us know the artery we should do a graft on and the ones we should not do. Also, the artery we should do a stent on and the one we should not do a stent on. And then we have the endomyocardial biopsy for infiltrative diseases. Then the next thing we ask ourselves, we have to stratify this patient. Will they actually survive the surgery? And then will they have better outcome after the surgery? And that's where the Euro score helps us, the STS score, the frailty index, like I said, it's not just the cholesterol age of the patient, but also the biological age of the patient, the comorbidity burden. Do they have chronic kidney disease, chronic obstructive pulmonary disease? Do they have any prior stroke? It helps us. And lastly, the heart team gets to decide, is this patient actually fit for surgery, and can then plan for surgery.
But I see that a couple of people have questions. Please put your questions in the box and then we'll tackle them when we finish. So after we've done all these investigations, we have to present the patient to the heart team. And the heart team consists of the cardiologist, the cardiac anesthetist, the perfusionist and the nursing team, the imaging people, and of course the cardiac surgeon himself. So the whole point is this patient an ideal patient for surgery? What is the best management plan for this patient? Because it is not always surgery. Even though the patient has a cardiac problem, the solution is not always surgery. The solution may be surgery and then something else, or no surgery at all. That's the essence of presenting this patient to the heart team, so that the decision is not one-sided, it's not just made by the cardiac surgeon, it's made by the entire team. So there are essentially four treatment strategies that are available. One is the medical management. Some patients are just not fit enough for a haircut. So the best thing we can do is put them on the best guideline-directed medical therapy possible and try to manage them as best as we can. In some cases, these patients improve enough to get some kind of intervention. So the other interventions that are available include catheter-based interventions, like the PCI, which is the stenting, particularly patients who have coronary artery disease. You can stent them. Patients who have aortic stenosis can get what we call TAVI, which is the aortic valve implantation, transcatheter or transcutaneous aortic valve implantation. Patients who have mitral regurgitation and cannot have a proper surgical procedure can get a mitral clip. And then TIVA is the stent equivalent of the coronary artery in the aorta. So you have patients who have aortic problems like aneurysms or dissections, we can stent them rather than giving them open surgery. Then sometimes we combine these catheter-based interventions with open surgery, what we refer to as a hybrid procedure. So sometimes we do stents and then go ahead to do coronary artery bypass for the other vessels, particularly when there's a patient that we know has multi-vessel disease, but then suddenly comes down with an event, like an end-STEMI or a STEMI. And so he's a bit unstable. We know that there's a culprit vessel that we can stent, stabilize the patient, and then bring him in later for proper coronary artery bypass graft for the other stenosed vessels. This will present, of course, to the heart team, and then we'll be able to arrive at exactly what we want to do. And then, of course, is the open procedure, where we have coronary artery bypass grafts, which is one of the commonest procedures that we do. It's the gold standard for coronary artery disease. And then we have valvular repairs or replacements, things that we do very easily, can commonly hear at Cardiocare. Aortic root and aortic arch surgery, and then repair of congenital anomalies. Now, this is just like a snapshot of some of the procedures that we can do in cardiac surgery. And of course, we can do here at Cardiocare. So coronary artery disease, the answer is coronary artery bypass grafts. So you can now decide to do it on pump or off pump. You can decide to do bypass with arteries and veins, both of them, or you do what we call a total arterial revascularization. Now it depends on the surgeon. There's a lot of discussion and preferences on what to do and what not to do. But the standard is coronary artery bypass grafts. And sometimes you have to combine these with valvular surgery. So broadly, if you have valvular stenosis, most likely it's going to be a replacement. Now, if you have a regurgitation, there's a room for durable repair. And if that doesn't work, then we'll go ahead and replace it. Now, the aorta spans from the roots, ascending the arch, then the thoracic and abdominal aorta, all through. We can operate on them, even here at Cardiocare, no matter how extensive the pathology is. And so it's also for the congenital heart diseases, whether it's seen in the adults or it's seen in children. And then we can combine these procedures with some other things, like the MACE procedures for patients who have arrhythmias. So if you have a valvular problem and you have arrhythmias, we change the valve at the same time, sort out the arrhythmia at the same sitting. So one of the most important part of this entire discussion is for us to understand that the outcomes you get in cardiac surgery begins before the patient gets into the OR. Because if the patient is not properly prepared and optimized, you will not get good results. The outcomes will be poor. If you do not have a robust discussion with your heart team to identify the best treatment plan for this patient, you won't get ideal outcomes. So first, preoperatively, nutrition. And when we're talking nutrition, we're talking over and under nutrition. So people who are malnourished, who are underweight, we need to optimize their nutrition first before we put them through the stress of surgery. Those who are obese, overweight, some of them might need to lose weight first before we go into for surgery. Now, of course, we're not talking about emergency cases, but if you have time to plan, then these patients should lose weight or gain weight, depending on where they fall into. Now, do you smoke? If you're a smoker, it's ideal for you to stop smoking before surgery. If you have other respiratory problems, you need to make sure that your respiratory system is ideal. Because, of course, you're going to be on the bypass machine, you're going to be on the ventilator, and you have a very high risk of respiratory tract infection and also respiratory failure if you do not optimize it properly. So you don't want to put the patient on the ventilator, do a fantastic major aortic procedure, and post-operatively, you can't get the patient off the ventilator. That's a no-no. It should never happen. So you pre-operatively prepare the patient respiratory tracts for all of the insults that it's going to receive. For the cardiac status, I don't think I should have to say anything about that. You expect that we optimize them as much as possible if it's not an emergency. Diabetes control is ideal. You have to make sure that the blood sugar is well controlled. Any patients who are on any nephrotoxic drugs before surgery, you stop them. Any drugs that you know that will cause problem even after surgery, excuse me, you need to stop them. Hydrate the patient as much as possible. Make sure that the kidneys are functioning properly. Sometimes you may have to postpone surgery if you think that maybe because of the contrast that the patient received, kidneys are not working properly. Allow the kidneys to recover before we go for surgery. Then the anesthetist is going to put up a fantastic plan of how they're going to put the patient to sleep, how they're going to wake him up, and how they're going to take care of him in the ICU. So now the patient has gone to surgery, we've done a wonderful coronary artery bypass valve, we've changed the aortic valve, changed the mitral valve. The first 6 hours is hemodynamic stability we're worried about. You have to make sure that the patient's hemodynamics is stable. You have to now start weaning off the ventilator. Make sure the patient is not breathing. Control the temperature as much as you can. So because we put the patients on the bypass machine, we have to modulate their temperatures a lot. Sometimes you have to cool the patients down. And so post-operatively, we have to rewarm them. In the next 6 to 24 hours, this is when we're planning on extubating the patient. Then you have to control pain, monitor heart rhythm, and fluid management. The next 24 hours, even here in Cardiocare, patient is already sitting out of bed, he's eating, we're moving him around, he's starting physio, first day post-operatively. And if the drains are not functioning, we take them out. 48 hours, and afterwards, patient leaves the ICU, goes to the wards, and begins to move, and we begin to plan discharge. So, cardiac surgery is not the end of the treatment. So we know the patient had a cardiac problem, we have operated on it, but that is only the beginning of a long-term cardiovascular care. After surgery, some patients will be on some medications for life. And so you have to make sure that patients are on the ideal medications. Excuse me. The patient needs anticoagulation, particularly patients who have mechanical valves. You know that they have to be on this warfarin for the rest of their lives. All of this must be monitored. Apart from the medications, patients need to have what we call cardiac rehabilitation. So rehab usually happens about 6 weeks post-surgery, and it's been said to reduce re-hospitalization, excuse me, by 28% and mortality by 20%. So we need to help the patient get back to their pre-surgical state. Then after that, we put patients on some kind of surveillance. So most times we don't just wash our hands off the patients after surgery. You have to keep an eye on them. Now, this doesn't necessarily have to be by the surgeon, but it has to be by a member of the heart team, usually the cardiologist. After that, you have to help them get back into their usual lifestyle. So diet, exercise. Those who smoke, just ask them to stop smoking. Those who consume a lot of alcohol, we ask them to be reasonable with alcohol consumption. And then, of course, secondary prevention is very important. Now, a part of recovery that is not usually addressed is psychology. Some people, after cardiac surgery, are scared to drive. They're scared to go back to life as it was before. Some people even plunge into depression. So you have to look out for these people and start some kind of therapy if you need to. Send them to a therapist, ask them to see a psychiatrist. And functionally, usually after the 6 weeks, we take off most of the restrictions, excuse me, and patients are able to go back driving their cars. They are able to resume sexual activities if they want to. For the younger ones, we say after 6 weeks, we may begin to go back to work gradually. For the older people, no gentlemen and gentlewomen now, it might take a bit longer, maybe up to 12 weeks. But then gradually, they go back to life as it was before. So what has changed in cardiac surgery and what remains constant? Nowadays, the concept of the keyhole surgery, what is referred to as a minimally invasive surgery. Everybody wants a scar that is that small. So there's VATS, there's robotic surgery, and many procedures have been done now through very small incisions. Of course, we have the transcatheter procedures like the TAVI and the TIVA for the aortic cases. And then the hybrid procedures we've been talking about. Myocardial protection has also evolved significantly. So when we're doing cardiac surgery, we need to stop the heart, but you have to preserve the heart. So we have to protect the heart against damage from ischemia, which is what we call the myocardial protection. And a lot of things have happened, a lot of different strategies have come up. Now you see that myocardial protection appears on both sides of the table. Even though we say that it's evolving and new technologies are happening every time, one thing we cannot replace is the fact that there has to be some kind of myocardial protection. Whatever technique you want to use, here in Cardiocare, we use what is called the needle cardioplegia. It allows you to work for 60 to 90 minutes without needing to top it up. So if you're doing major aortic arch procedures where the blood supply to the brain will have to be cut off, you need to protect the brain. So that's what we call cerebral protection. That doesn't change. You cannot starve the brain of nutrients and expect it to function properly after surgery. So there are different ways we do this. We can cool the patient down significantly, and then we perfuse the brain either antegrade or retrograde, just to make sure that when we put the connection back, the brain goes back to normal. And of course, meticulous hemostasis needed for every form of surgery. And then the conduct of bypass, that's putting the patient on the bypass machine, doing your procedure, and taking them off the bypass machine. Surgical precision, I think, everybody understands that. So, there are 5 things that we want us to take away from all of this discussion, which is that the outcomes you get after surgery begins at diagnosis. The decision is not a one-man decision. So you can say you're the cardiac surgeon, you're the king of the jungle, you're on top of the food chain. But now, in the modern day cardiac surgery, it doesn't work that way anymore. You need a team. You need people who have different expertise, who will be managing this patient with you to also give their input so we get the best outcome for the patient. It is not you doing the most complex procedure possible, but which procedure is best for this particular patient. And timing, we say, is a clinical skill. You need to know exactly when to operate. And we don't faff around until then it's too late. Perioperative optimization is not optional. In fact, it is the rule. You have to optimize your patient properly. And then recovery is not just an event. The recovery is a program that spans months and even years. Thank you. I'm sure you know that we do monthly health walks. We're having another one tomorrow, and we'll be happy for you to come and join us. So we'll just quickly look at the questions that we have here. And fantastic that there are no questions. I want to believe it's either that you understood everything we have spoken about, or you have no clue what we have been saying. I will wait around to see if there are any questions. If I don't see any, then I want to believe that it's the first one I said. We have a thorough understanding of what you said, and we know how to now properly prepare a patient for cardiac surgery. We'll just give you a few minutes for the questions. Someone wants to know what's happening tomorrow. Tomorrow there's a health walk that we do here in Cardiocare. We'll start from the CBD Central area. And it starts at 7 a.m. in the morning. Everybody's welcome. We do this on the last Saturday of every month. And so the one for the month of May is happening tomorrow.
We're still waiting for more questions if there are any.
It says, would medical students be allowed to assist at any capacity? I'm sure you understand that it's any form of cardiac surgery is high risk cardiac surgery. And first, we need to understand that you appreciate how you should conduct yourself in the operating room or the operating theater. So if we are sure that you understand these things, you know how to, and we know who you are, there are ways in which we can incorporate you into the team and get you, to be part of the operating team. I'm sure you understand that you can't just show up and say, I'm a medical student from Jamaica and I want to be part of the surgery and I'll allow you to come and assist me. But yes, there are ways in which you can allow students to be part of the procedure. So the walk tomorrow is a walk against hypertension. And like I said, it's open to everybody. We welcome you all to join us.
At 7 a.m. tomorrow morning
At 7
at Central Business District. And also, we're open for referrals as well. So if you have a patient who you think need a cardiac surgery, you can refer them here to be assessed clinically, and then decision will be made if surgery will be beneficial for them or not. Thank you.
I think that in the absence of any more questions, we'll be wrapping up this webinar. But before we go, there is an important person who would like to share something with you. Thank you.
All right, so thank you all for joining this webinar today. I hope it was worth your time. And you can see on the screen, if you want to refer to us, you can reach out to any of the numbers that you can see on your screen. You can also email us at frontdesk@cardiocare.ng. So we hope to hear from you, and we hope to see you next month. The last Friday of every month, we do these webinars. And we have a WhatsApp group that we post reminders, we post programs for indigent patients. So please kindly use the link that is displaying on the screen to join the WhatsApp group. Thank you so much for your time. We hope to see you next month. You have a wonderful evening. Bye.
Thank you.